Ulcers after gastric bypass surgery are relatively uncommon and can typically be treated with medications, but sometimes can become very significant problems. So the ulcers that we see after gastric bypass are referred to as marginal ulcers, and there's about a 1 to 3% lifetime risk of having a significant marginal ulcer. And this is a problem that is unique to gastric bypass patients. That's, I think, something really important. It's not just gastric bypass patients. We can see it with other forms of gastric surgery, but based on what types of surgeries are being done today in the United States, about 99% of the time when someone has a marginal ulcer, it's after a gastric bypass. So this is not kind of a traditional ulcer like you would think of, and it's a very special type. And it all has to do with the gastric bypass anatomy. And what we see with gastric bypass is that there is some acid that's made in the stomach pouch, and that the small intestine that's connected to this gastric pouch is not designed and hasn't typically been exposed to acid. So it doesn't have a good acid barrier. The first portion of the small intestine, which is right down here, actually is very resistant to acid. Not entirely resistant, we can get ulcers there too, but it's more resistant to acid than the remainder of the small intestine. And so as a result, we get an ulcer that sits right here. It's right on the margin of the small intestine and the stomach, and it's right at that connection. And we call it a marginal ulcer. They always occur right at the same spot. These are typically not something you have to go hunting and looking for endoscopically. You're going to see it right at that junction. Sometimes there can be some folds and they can be tricky to see, but they're always there. And we diagnose this with endoscopy, where we put a scope in through your mouth while you're asleep and we put a camera in and we can see that ulcer. We can't treat it with endoscopy, but we can make the diagnosis. So the causes of marginal ulcer, there's a bunch of different causes out there. Smoking is without question the #1 preventable cause. And I'll have another video about smoking and why it's so important to quit smoking as soon as possible in the decision-making process. But when I work with patients who are looking at a gastric bypass surgery, who are smoking when they come into the office for their first appointment, we spend a lot of time discussing how critically important it is that you stop smoking as soon as possible and that you commit to a lifetime of never smoking again. A gastric bypass patient who smokes after surgery, and you can quit for 10 years and then 10 years down the road, start smoking again, and this will happen to you. You will get an ulcer. It's a matter of time until you get an ulcer, and it will be a miserable ulcer, and it will take months, if not years, to heal completely. And then it will come back, especially if you continue smoking. And the worst thing about it too is it's not like, oh, well then you quit smoking if you get that ulcer and then it goes away. It doesn't always go away, and it persists even if you're not smoking, again, for months and years, and can make you totally miserable. So if you are not fully committed to smoking, please do not undergo a gastric bypass procedure. You will have nothing but trouble. That is my personal guarantee to you. Non-steroidal use. If you are really dependent on ibuprofen, Advil, Mobic, or medications for your joints, and especially if you're working to stay off narcotics, which is critically important to your overall health and well-being, and find that you don't think you can give up non-steroidal use, this is another important reason why I would shift someone toward a sleeve gastrectomy as opposed to a gastric bypass. So if you feel like you're dependent on non-steroidals, then probably best not to proceed with a gastric bypass. Now, there's a common misconception that you can't ever take another Advil tablet again for the rest of your life. In fact, you absolutely can. If you have a headache, you can take an Advil tablet. It's not going to cause a marginal ulcer. It's the high dose over a sustained period of time. Now, that could be 5 to 7 days. It doesn't have to be several months of treatment, but that occasional one-off dose of Advil or some similar non-steroidal medication is going to be fine after a gastric bypass, but it's the regular, continued, and high-dose treatment that must be avoided at all costs. Steroid use as well. If you regularly take steroids, steroids absolutely can cause marginal ulcers. If you have a personal history of ulcer, you're obviously prone to making acid and prone to developing ulcers, then you will more likely develop a marginal ulcer after surgery. And then finally, diabetics have higher rates of marginal ulcers, especially if they don't get a complete resolution and have continued high blood sugars, which can be immunocompromising and almost have a steroid-like effect that breaks down the lining of that small intestine, exposing it to a higher rate of ulceration. So these are the 5 risk factors that we typically see. And then really the kind of the 6th risk factor that I talk to patients about is bad luck. You know, there are people who have none of these issues at all and still develop ulcers. So the symptoms that you have when you develop a marginal ulcer are lack of appetite, difficulty swallowing. Everything you eat really kind of just, it hurts to eat. Food becomes painful. You almost develop food fear. And something that I see, and sometimes patients will come in and say, you know, actually this is pretty good. I've lost 15 or 20 pounds. I haven't even really been trying. Unintentional weight loss, where you're not making a sustained and deliberate change to your diet, but instead it's the consequence of certain symptoms that you have, is a very insidious and worrisome symptom that must be fully investigated. And so any patient who to me comes in and says, I've lost 15 or 20 pounds without trying, we are doing an endoscope to make sure that they don't have a marginal ulcer, and potentially doing a colonoscope too to make sure that there's not a colon cancer or something like that. So if you're losing weight without trying, this requires immediate medical attention. You can start with your primary care doctor, but if there's GI symptoms involved, again, go see your bariatric surgeon, not a gastroenterologist, someone who's really familiar with these ulcers and how to treat them. Iron deficiency, if again, spontaneous iron deficiency 5-10 years down the road, it can just be from poor absorption and finally depleting those stores, but it also can be from a marginal ulcer. So this needs to be investigated. And finally, upper abdominal pain, sometimes radiating to the back. Patients will describe it's really almost right underneath the breastbone, almost into the chest, at the highest part of the abdomen, and again, sometimes radiating into the back. Those symptoms are worrisome for a marginal ulcer, and oftentimes you'll have some tenderness where if you push a little bit, it hurts there as well. So these are the symptoms to watch out for, and this can occur at any point in time, and especially if you have some of those risk factors, this is something to discuss with your surgeon or at least your primary care doctor, but really your bariatric surgeon should be your first touch point for treating marginal ulcers. So they typically occur within the first year of surgery. I personally keep people on an acid blocker for 1 year after a gastric bypass surgery. Not after a sleeve, but after a gastric bypass for 1 year in an attempt to prevent marginal ulcers, which again, typically occur in the first year. They can occur anytime. The ones that occur in the first year, we can almost always get to heal on their own spontaneously. The ones that I worry about are those that pop up 5 and 10 years down the road, especially if they're related to smoking or prolonged nonsteroidal use or other risk factors. Those tend to can become chronic and become very difficult problems to treat. The treatment is acid blockers. There's 2 that I use. I use Protonix, or a proton pump inhibitor, at a high dose. And I also use a drug called misoprostol or Cytotec, which is kind of an old-time acid reduction, or actually it helps with the healing and the barrier formation of the small intestine. And I find that to be a really, really helpful and generally well-tolerated medication. We'll also use Carafate as well, which is something else that helps to coat the small intestine. Some things about the acid blockers and the Carafate, how you take them matters. There's some good evidence that shows that if you open up the proton pump inhibitor and make a little slurry, instead of just taking it as a pill, that you get faster healing of the ulcer. The other thing is the Carafate, it matters if you take it as a slurry. They have an elixir formulation. The elixir formulation is like $200 or more a month. The pills are very cheap, $10 a month or something like that. So I have patients get the pills and make a slurry with it by dissolving it in water and taking it that way. You can go in and resect the ulcer. You remove that portion of small intestine, so it would be something like this. If this is the ulcer right here, you would divide here and then reattach up to there. The problem is that you don't have an unlimited amount of stomach. So you can generally get away with this once, but multiple surgeries to resect ulcers are generally not possible. When I work with patients, especially someone who's smoking, I make sure they quit smoking well in advance before I do something like this, and do everything we possibly can to set you up so that this one surgery we do is the only time we have to operate, because there may not be an option for a second surgery, because essentially you run out of stomach to work with. And then what I've had to do once is reverse the gastric bypass, where we had almost no stomach left. The ulcer had recurred multiple times, and we basically found ourselves up against the ropes and weren't making any progress, and we had to actually reverse the gastric bypass as a treatment of a chronic marginal ulcer. And that is the most common reason why a gastric bypass is reversed, is for treatment of a chronic marginal ulcer. I've done over 1,000 gastric bypasses and I've reversed one. So I think that goes to show you how uncommon it is that we need to do it, but this is the scenario where it would need to be done. So the bottom line is that marginal ulcers after a gastric bypass are preventable by avoiding smoking and nonsteroidal use in most people, but they may be unavoidable. They typically respond well to medications, but it is not the most pleasant medication regimen to be on. It's 10 or 12 pills, sometimes for a few months, to get these things to heal. And in rare cases, they can become chronic and very debilitating long-term problems.